Hi, my name is Professor Igor Rudan, and I will show you today how do we use the PATH tool, how do we implement the PATH tool. You have seen that quite seemingly complicated conceptual framework in my last presentation, but it all becomes quite more simple when you start using this tool. The tool is simply an Excel sheet, and everything that I was showing you in those many slides is actually now here in this one Excel sheet, and I'll take you through it. So you see all those different branches of the trees are now shown in this one slide, and we are now down to secondary healthcare, remember, and then moving up to what happens from the primary healthcare. And you see that some of them are being referred. You see here what's happening at seeking treatment at the community health worker level, and then at seeking treatment at home, or actually self-treating at home. You can see that the clinical algorithm is important everywhere. That's this table, the yes and no. And this is the top of the Excel sheet, and we will now zoom in to see what it tells us. Okay, so this is what it tells us. It tells us many things that you would not be able to intuitively understand. So these are the parameters, all the parameters that you will need to construct your PATH tool in any given environment, anywhere in low and middle income countries for any disease. You will need the number of people who could be at risk of getting a disease or dying, and then the proportion which seems to have contracted the disease, proportion who seek care, proportion who really developed the disease, case fatality rate if they were not treated, and then proportion of those who seek care and receive self-treatment, proportion of those who seek care and receive community health workers treatment, proportion of those who seek care in primary and then secondary health care, effectiveness of self-treatment at home, effectiveness of community health workers treatment, effectiveness of primary healthcare treatment, effectiveness of secondary healthcare treatment. Then you need a sensitivity of home-based diagnosis and specificity of home-based diagnosis, but also for community health workers diagnosis, for primary healthcare worker or physician's diagnosis, and for secondary healthcare diagnosis. And finally, you need a proportion of parents who comply with treatment, if this is an issue, or this could be patients who comply with treatment, and proportion of patients who comply with referral from primary to secondary healthcare. So those are 23 parameters that you need to have for any context and any disease if you want to understand the so-called health systems autopsy of all deaths. So health systems autopsy is kind of a social autopsy, but it's really, from the perspective of health system, it is letting you understand how are you failing certain patients and the people who need health system and treatment, and where are you failing them, and what could you potentially change within this health system so to save many of these people. And let us play with it a little bit, because here is what we now believe to be true for an example of newborn global deaths in 2011. So of about 907,000 deaths, we assumed from the PATH tool that about 352 died because they did not seek care and did not receive any treatment. So over a third. And then that some died although they did seek care but self-treated and did not respond. Some died although they sought care but community health workers treated and they did not respond. Some died although they sought care at primary health care facility but a doctor there missed diagnosis and didn't treat. Some died although they sought care and primary health care doctor intended to treat but parents didn't comply. Some died although they sought care and primary health doctor treated but parents couldn't go to the secondary health care. Some died although they sought care at secondary health care but the doctor missed the diagnosis, and some died although they did seek care at the secondary health care treatment and the doctors there tried everything but simply the child did not respond. So these are the deaths that we will it will be very, very difficult get to zero, this 136,000. But actually everything before that, there is a hope of reducing those deaths. So clearly there is still a lot of opportunity for reduction. Now let's see what happens when we move some of these parameters and change them. So the number stays the same. Proportion of symptoms stays the same. Now, if we could change care seeking from 69% to say 85%, let's see what happens. See, immediately you understand where you are saving lives. So you're saving lives everywhere in all of these. The only so you're saving 53,000 lives globally. You see that the number dropped from 907,000 to 853,000 in the cell AU12. Okay, so you see where these actually come from, okay, and how this happened. Okay, now let's go back and try to do something else. All right, what if case fatality rate of untreated sepsis could be changed? But so this is something that, well, untreated sepsis, that's a property of disease, so we can't really, so that's not really what we're after here. We are here perhaps to change the, say, proportion of those who seek care in secondary health care rather than self-treat. Okay, so let's say that we increase this by 10% and we decrease this by 10%. You see what happens now? If rather than if we could shift those who self-treated at home, if we could shift 10% of the total with symptoms from self-treatment at home to actually immediately going to secondary health care, we could save 37,000 lives. But you see how? I mean, these things are not intuitive at all. So let us see, how did this save lives? Basically, here you had a number that was bigger than 100,000, but now 74,000 of these deaths were saved because they were shifted from home care directly to secondary health care. But what happened at the secondary health care is that we now have a worsened situation. We have more deaths because the doctor missed diagnosis and did not treat, and because the doctor treated but did not respond. But more patients now came to secondary health care, and this is why we have more deaths here. But the net effect, as you can tell, is 37,000 child deaths saved. So you can see how counterintuitive this is and how actually complicated, but it becomes simple when you see it here. So let us go back again and try something else. Let us say if we could increase effectiveness of self-treatment at home by somehow providing everyone some magic pill, and if it could be 90%, let's see what would happen. Suddenly we would save 50,000 lives immediately, but only in that row, self-treatment at home, right? Going back, what if we could improve effectiveness of primary healthcare treatment, which at the moment stands at 35%? What if we could raise it to almost 90% by some splendid intervention at this level? You see, that could lead to 40,000 deaths reduction, and that's probably unrealistic, but yet still only reduces 40,000 out of 900,000 deaths, even these figures are global. What if we could improve effectiveness at the secondary healthcare to 100? You could save 136, you could save everyone who comes to secondary health care. So that globally, in global terms, is reduction from 907,000 to 770,000, so that's still a limited potential. But what would be great is if this would be possible, simply because then if we could build enough hospitals and get every child to the hospital, we would no longer have any deaths of sepsis. But this is beginning to show you how unrealistic many of these scenarios are, and just how far we are from getting completely rid of these problems. Okay? And just how much do we need universal health care, and how much do we need excellent and quick rapid diagnostics and reliable diagnostics and good treatments, okay? Good. What if we could, for example, improve sensitivity of home-based diagnosis to 100 and specificity, or just let's start with the sensitivity. With the sensitivity, we would save some lives. The effectiveness of treatment there is not terribly great, but we would save some lives. But now check this. What if we also move specificity up? Remember, 6281, all right? You see, nothing happens. If you change specificity, nothing happens. Let's move this back. Let's move sensitivity back. And you see, specificity simply is not important at the home care level. So let's put it back. We could put any number here, it's not going to help. What about community health worker? Let's put this to 100%. We save 7,000 lives, all right? Let's put it back. Let's now change specificity to 1. Nothing happened, all right? Nothing. You see, you would not know these things unless you have this kind of tool to help you understand. Then what would happen if primary healthcare worker or a doctor had a perfect sensitivity of his assessment? Oops! All sorts of things happen, all right? And you save 35,000 lives. So this is telling you there is a potential there. There is a potential if you could improve sensitivity of primary healthcare workers' diagnosis from 70% to 100%. Look, there is quite a decent potential to change things. And let's get it back where it was. What happens at specificity at this level? Absolutely nothing, all right? So it's just not useful. Sensitivity is important. And then again, you have secondary healthcare level, sensitivity, specificity. Let's put specificity first to 100 just to see whether it matters here. No. So it just doesn't matter anywhere, really. And we don't need this parameter at all. So we need to really be focused entirely on sensitivity. What happens at secondary health care if you have 100%? Look, it is really important. It still has quite a decent capacity, and it does save 21,000 lives, even just the change from 90 to 100. So that means that sensitivity at the secondary health care level is a really, really important thing, because you're capturing all sepsis and you're providing them treatment. You really don't want to miss sepsis case. You really want to be as sensitive as possible at this level. So you see, those are things that are useful to know, but you would not think about them. Now, what happens if a proportion of parents who comply with antibiotics at the primary healthcare level moves to 100% from 90%? 9,000 deaths saved, all right? So there is a lot. So you see how important it is to ensure compliance. That you would not think that that would matter much from 90 to 100%, but it does matter. And what about proportion of parents who comply with primary healthcare referral to secondary healthcare if it goes from 60% to 100%? 12,000 deaths saved. Again, quite a decent life-saving potential. So I hope I've shown you just how helpful this is, even if these parameters here that we use them are completely wrong, and I mean, they're still kind of internally consistent and they still add up to the right correct number of deaths. So if one is a bit higher, the other is then a bit lower, but they're not going to be terribly of, and they are based on quite a lot of evidence that we did manage to gather, and some expert opinion as well. So they may be wrong, but they're not terribly wrong. But what helps here really is, whether they're wrong or not, it really helps you to understand what and where lies the potential, and also the limitations to reduction of newborn survival. Now let's do the ultimate experiment. Let's try to be as good as we possibly can in everything. So what would happen if proportion of those who seek care in primary health care, what would happen if everyone goes to hospital, straight to hospital? What would happen then? Everyone goes to hospital. Ooh, we are dividing by 0 here in some of these. Oh, we shouldn't have 0. Maybe we should leave 1%, because one thing leads to another. So okay, so yeah, these things are somewhere in a denominator, and maybe it's good that I made this mistake, because others would wonder what's happening. So let's say 97% of them end up in the hospital. Let's see what would happen. See, this is really striking. If everyone went straight to hospital, you would save 169,000. You would think that you would save more. So where is the problem? The problem is with care seeking. Okay. Now, what if care seeking went to 95%? Ooh, now you're saving 320. What if care seeking went to 100? Now you're saving 350,000, but you're still left with 557,000 deaths. How come? So basically, you are having everyone seeking care, and you are having 97 people going to a hospital. Why are you still having 557,000 deaths? Well, let's read. Died, although sought care but self-treated, did not respond. That's 10,000. So those are those 1%. But where are they dying? Died, although sought care at secondary health care, but secondary health care doctor missed diagnosis and didn't treat. And finally, died, although sought care at secondary health care, and doctor treated but did not respond. This is where they are dying. They did not respond. They simply did not respond, and we simply can't do much. But why is this? This is because the effectiveness of secondary healthcare treatment is standing at 58%. Okay? So what if we increased that to 90%? Now we're talking, okay? Now we're talking. Now we are having the deaths of sepsis reduced to 237,000. But still they're dying. So what else could we do? We could increase sensitivity of secondary healthcare diagnosis, right? To absolute perfection. What happens? Ooh, we're down to 138, okay? So, and compliance, I think here should no longer matter, but let's just see. No, it doesn't matter. So this is what could potentially be achieved over time. To go from 907 to 136, what would we need? We would need, firstly, we would need everyone to seek care, right? Everyone to seek care, that's this number 1. We would also need those who seek care, 97% of them, to immediately go straight to hospital. We would need the effectiveness of hospital-based treatment to be 90%, and we would need the doctors at the secondary healthcare level to have a sensitivity of 100%, and then you would remove 770,000 deaths, and you would still be left with 136,000 deaths, because simply some did not respond. So do you understand now this a lot better? I think this is remarkably useful to explain to you where are the limits to what you can achieve, and the limits to impact, and how and why kids die from newborn sepsis from the perspective of health systems. So PATHS is really health systems level autopsy of deaths in low and middle income countries. Okay, thank you very much for your attention.